Usually when I do kind of like public speaking engagements, I just kind of black out, honestly.
So if you think of psychology as not, it is a very rewarding practice. It is a enriching, helping kind of area space. But at the end of the day, it is also a part of making money and a business.
For example, if you guys have invested so much in your education and you are so qualified, then the country is losing out on somebody who would love to go back to the country and work over there, but they can't.
Did you solve unemployment? Wow, I like that.
I would like to run for elections.
Mental health issues pretty much are always show up as physical health issues in South Asians.
South Asians don't know their own history because historically we have been very prone to famine.
Yeah, exactly.
Because we were so prone to famine, our bodies had to readjust a lot.
Exactly.
Since that time, generationally now, we are not very tall and we store a lot of fat and all of our problems are stored as physical manifestations.
Yeah.
Exactly.
An aunt of mine had to go to therapy. So the fact that she had to visit a psychiatrist was like discussed in the entire family. Like, oh my God, she has to go to a psychiatrist. What is wrong? What is it?
It could be as simple as your best friend moved away.
Your best friend
Yeah.
moved away.
Your whole identity was attached to that person.
Oh, and the millennials in the middle are just like, we don't even know what's going on.
We don't know what's going on. We had CDs 2 minutes ago. Now we have iPhones, iPods. Wait, no, they're gone too.
Yeah.
I don't know where they are.
Welcome to The Best Part is Season 2, Episode Whatever with Sid and Adi.
That's right. We don't know our episodes because we don't number them. So, so it works great for us.
Well, today we have a guest.
Yes, we do. We have Sharanya Venkatraman, who is a psychologist. Yay!
Hey, let's go.
Okay, cool.
Our first guest.
Our first guest.
Oh,
That's true,
Oh,
yeah.
I didn't know that.
So we
Quite
are
the
now.
honor.
So for everyone to know, we are venturing into getting local people on. So either you're a professional, an expert, or you know something very specific to you that other people don't know about. And the parts that are best about it, we talk about it.
Yes.
Yes.
Come here and spill your guts. Tell us all your secrets.
That's right. We won't mock them. Okay, cool.
I'm a psychologist, open book.
Open book. There you go. See, awesome. So we have you here today to talk about a very specific kind of topic. We're going to talk about the decolonization of therapy. She's very big on this front. She recently presented in the International Psychology Conference of Dubai regarding this topic, which is a fantastic feat. Congratulations.
Thank you.
How did that go?
It was quite interesting. Like, it's like I had my whole presentation done like a few days before the conference, and then like, I don't know, like the night before or something, I was just like, I don't know, something about this just doesn't feel right. And then I like revamped the whole thing and I changed the whole thing.
Just the night before the show.
Yeah, the night
That's
before.
Great.
Because I felt like I wanted to kind of break it down more into like decolonizing, not just like the actual practice of doing therapy, but right from the beginning of how do we educate psychologists? What does academia look like when it is decolonized? What does research look like when it is decolonized? And then like clinical practice.
That's right.
So
yeah.
that was my thought process, and I just revamped the whole thing, and it went well.
Oh, that's great to hear,
Yeah.
though. Even though we did a last minute thing there, we pulled it off.
How stressful was that?
I mean, usually when I do kind of like public speaking engagements, I just kind of black out, honestly.
So she didn't know what happened. Just happened.
It went well, I guess.
24 hours ago, I was there, and then 24 hours later, it was done.
Yeah, like that whole talk part, I just black out. Like I'm just like, I don't know how I do what I did, but then I did it and it turned out well, and I guess I'm just gonna go with it.
Go with it.
Amazing. Awesome.
So you're a psychologist, I'm a psychologist. Our friend here is an expert on many things.
I'm
but
psychology adjacent.
He's psychology adjacent. He's an ally to the psychological dream. But for the rest of our people and our listeners, what exactly is decolonization of therapy?
Okay, so first I just kind of ask people to think about what is colonization, right? What do we mean when we talk about colonization? It is basically someone else trying to erase your beliefs, your cultures, your way of being, and trying to impose their way of being onto you, right? It's about power, it's about privilege, it's about this sense of superiority, right? And a sense of entitlement. And this is the right way of being. So decolonizing is exactly the opposite of that. Therapy, historically, the most amount of research and conversation and theories and happened in Western societies, and it continues to happen in Western societies. And a lot of what comes out of this research, comes out of clinical practice, is very much geared towards Western societies, and then it is pushed onto non-Western and non-dominant cultures and societies. And that's where that kind of erasure of way of being occurs, you know? No, this is what, these are the skills that were researched and tested, and empirically supported evidence supports this treatment, so you have to go about being this way. This is how we need to do it. But cultures are different. People are different, right? So that's kind of what decolonizing is moving away from Western ideals and practices of doing something and incorporating and coming closer to what people's culture and identity people have been doing for like millennia.
Correct.
Yeah.
And it's also viewing it, I think, in the broader perspective, it's also viewing it as not just for a certain group of people.
Yeah.
And increasing the accessibility of it. Because a lot of
100%.
people would even remove themselves if they think this is too, for lack of the better word, quote unquote, white.
Oh,
If it is too, quote unquote, white, they will remove themselves
for sure.
from this concept.
For sure.
But to be very honest, like as somebody who's not part of the psychology world, I was very surprised. I think I found out about decolonization of therapy last year or something like that. And at that point of time, the examples that were given to me in our conversation were why some things are needed. I was like, isn't this already happening? Because for me, there are so many different cultures. I was like, okay, maybe if therapy is happening in Africa, if therapy is happening in Korea or India or Dubai, where we are, they would incorporate those things already. But then I found out that no, that's not the case because that's not taught.
It's not taught. It's something you kind of have to figure out on your own once you start practicing, you know. So for me, I moved from the US over here, right? My training was in the US, all my experience was in the US. And then I moved here, and it was like a cultural shock for me. A lot of the things that I had been trained in, even though training, they try to incorporate as much of diversity and working with diverse populations, if you don't actually end up working with those populations and you understand it from a theoretical standpoint, and it is, you know, white professors teaching you these things.
That's right.
And the manual is exactly the way, the treatment manual is exactly the way it was designed for the weird populations, and by weird, it's white, educated, industrialized, rich, democratic groups, right? If it was designed for them, and that's what it's taught. That's what it's taught. And then I came here and I was just like, something's not working. Something's different.
It really doesn't work because, so you're trained in the US, I was trained in the UK.
Yeah.
So, funnily enough, it was not a conversation we had while we were studying. Okay? So, even when I was working, so I worked with a schizophrenic population for my research that I was doing there. And I was working with the PPI group, I was working with community outreach, I was working with various organizations, and not one organization or anything made me think of the fact that the whole group of schizophrenics that are in front of me are all white. Okay? Now, does that mean non-white people don't have schizophrenia? Or do they not recognize schizophrenia the same way?
How many, what was the sample size?
They were 12. They was testing a very specific VR intervention for for this particular research group. And then the question arose later, much later in my life, when I was working with other populations, that I was like, okay, are there no non-white schizophrenics, or do we not know how schizophrenia works in non-white people? Because culturally, in many cultures, correct me if I'm wrong, visions and hallucinations are considered godly. Or culturally,
Yeah.
culturally
Yeah.
embedded. So a lot of people wouldn't even identify it. There was a question that was asked to one of my professors by a person who came from Africa, and they were like, if I hear these, there was a simulator that would simulate the idea how auditory hallucinations
Yeah,
work.
yeah, yeah.
Right? He was obviously seen
Yeah.
it. So when so it sounds like a muffled, noisy white noise,
Okay.
and the words are only clear to the person.
Okay.
Okay, so they make sense to that person. It's kind of that kind of a voice simulator.
Okay.
So it gave us.
So this is a app or some sort.
No, it's not. It was just an audio note,
Oh,
for
okay,
example,
fair enough,
right?
okay.
So it was an audio note that was played for the class, so that we understand how a person dealing with schizophrenia hears auditory
So
hallucinations.
how did they get that? Like, I'm going off track, I know, but
I don't know. They made it probably.
So-
Probably made it based on the two things that I know that they used was from examples and from imaging. They got the information.
interesting.
That particular one, but I am.
So
not
I
clear.
actually, there's this creator I've come across on Instagram who is diagnosed with schizophrenia. He lives with schizophrenia, and he spreads a lot of awareness about the disorder, because there's so much stigma around it, and it's like this understanding that if you have schizophrenia, you cannot exist as a functioning individual in society, right? And he tries to dispel those beliefs that we have. And he actually had a reel where he kind of played what auditory hallucinations sound like.
Yeah, okay.
And I think he had mixed it himself.
oh wow.
And it's actually kind of terrifying, honestly.
Yeah, it is.
It is very scary.
Even the one that they played for us in the class, it was a lot. Like if that happened in my brain all the time,
Yeah.
anyone would be dysfunctional.
Exactly.
It made sense.
Yeah.
And I know the creator you're talking about. Is it the guy who uses the camera to identify if someone's behind him?
Yeah.
I
He
love
does,
those
he
videos.
does, yeah.
He goes like, "Hey guys, could you tell me if someone's behind me?"
Yeah, he
uses
does.
the phone camera.
This is beautiful. This is literally from Cinderella Man. No, Cinderella Man. No, Beautiful Mind.
Oh, yeah,
So
is
towards
it?
the end of Beautiful Mind, spoilers. The movie came out in 2005. It's fine.
Just 20 years ago, but okay.
Russell Crowe meets somebody. So Russell Crowe throughout the movie has hallucinations about the CIA coming to work with FBI coming to work with him, and then towards the end they want to give him a Nobel Prize for his accomplishments in math. And somebody comes up to him and he's like, he turns to his student because he's a teacher now, and they offer him this, and he's like, that's exactly what I'd like to hear. He turns to the student, excuse me, could you see him? And because the students know about him, they're like, yes sir, he's there. And then he just walks off. I'm like, it's become casual. It's like,
Yeah, so this is how most people recognize, even schizophrenics, they deal with the world and such like this. The only thing with that, asking another person, they also have to clarify if the other person is. So I'm just saying, just a little bit of an issue there. But okay.
Can you see him? Yes. Can you see her?
That's why the camera works better. But yes, so in that classroom, the person from Africa asked them, but in my culture, listening to auditory hallucinations is a good sign. Okay, from a very specific tribe that they were from, it's a good sign. It means that God is speaking to you.
Yeah.
So in that case, when you go for therapy and somebody goes like, no, you have schizophrenia, it actually creates more of a problem for the patient than less.
Yeah.
But now there's a different question that comes, and this is me asking as a religious person. A lot of the people who are doing these researches don't really believe. I mean, I'm not saying they don't believe in religion. That would be a very wide generalization. But they don't incorporate religion in their researches,
Yeah.
do they? So it's not a big part of their focus, and that is just not even considered. So how do you incorporate all of that into therapy?
So, well, first off, I think like when it comes to just diagnosing anything, right? One of the biggest criteria that we have to look at is how much are these symptoms impairing the person,
Okay.
right? How much are they interfering with their ability to function and go about their life at a level that's kind of developmentally like appropriate to their age and stuff like that, right? And that kind of gets missed out if we're just saying like, oh yeah, this is a bad thing that you're hearing these voices. You need to do this kind of treatment now, and you need to go on these antipsychotics, and you need to be in this hospital, and this is the kind of treatment that you need to receive, right? And if that kind of goes against what is practiced within the culture and the rituals that are practiced within that tribe, within that community, we do more harm than good, right?
Yeah.
Which is why, not just in therapeutic practice, but also in research, it is so important to incorporate leaders within the communities that we are studying, right, or working with. And that's a big part of that decolonization process. And it's shown like, it's called community-based participatory research, CBPR. And it shows like such robust kind of results that come out of it, such treatment that can actually be generalized. What this looks like is, when we are studying a group of people, we actually have people, not psychologists, but just people who live in that community, contribute to the research process and the way the research is designed, the way the assessment tools are designed, the way the results are interpreted. So this was done in like urban neighborhoods in the US, and it was also done in India in healthcare facilities. And there was like really good kind of outcomes that came out of it, and understanding not just like what we're trying to answer with this research, but how can we kind of take it forward into practice as well. Yeah, so incorporating leaders, incorporating people within the community is super, super important when we're working with someone belonging to a very kind of niche community.
But that would also need you to have people from those communities to come up, because, for example, if I were to go to a community that I don't belong from and I approach a leader of that community, they will be mistrustful of me.
Absolutely.
Because I'm an outsider.
Yeah.
It has to be someone from that community. So I come from a village in UP, Azamgarh. So I am considered trustworthy because I'm one of them. Even though I have not grown up over there, or I'm technically not from there because I've just been there like 4 times, but I am seen as one of them.
Yeah.
But if somebody else were to come and speak to them in that sense, they wouldn't trust them.
Absolutely.
And even me, when I say, when I say certain things that go against their beliefs, they say, you are not from, you don't live amongst us, you've not lived here, you don't know our ways, you don't know how things are done. And they are very non-receptive to those things. So I think people should come up from those communities as well, which kind of brings me to another question I wanted to ask both of you actually. So you guys mentioned that this is not actually taught in academic circles and everything.
Yeah. Not in its completion, not in its, not in a robust format.
Not in a robust. So it's not a major focus.
No.
Okay. Are there psychology experts from different communities from out there who've written textbooks, who've written journals that can be used for academic purposes, or are there none?
Absolutely.
Available?
I mean, there 100% are. And I know like with Native American populations, a big name in that kind of psychology, in the field of psychology and research and disseminating the interventions, is Caroline Atneve. She passed away, but she did a phenomenal amount of work when she was alive and trying to kind of bring psychology into the Native American community in a manner that in a language that is acceptable to the community, that is respectful of the community, right? So there are plenty of researchers like that. Even like, there's a lot of big names in psychology but they're not so big that, they just kind of come to the top of your mind, right?
Yeah.
The big names are still like Marsha Linehan, Aaron Beck, Stephen Hayes, all like white people. Right? So if you ask me to like kind of name like major researchers off the top of my head, I can't. But there are.
But is it because they don't get the exposure that they deserve, or they don't place themselves in positions where they can get the
No,
exposure?
so some of these names that she's taken, like Aaron Beck, for example, they've been around for a much longer period. Like they have a whole Beck Institute, for example. Yeah, so it's just like, think of it, I'll give you in a very layman term, think of it as movies. When you talk about the greats, when you talk about directors who are the greats, you talk about a certain class of people.
Scorsese, Tarantino, Spielberg.
Let's check, their ages are all older.
Yeah.
Yeah, and they're all white.
White.
So it's the same idea. So it's the same idea that when you're
Ryan Coogler.
Yes,
for the Sinners fans out there,
I know. Yes, like it became my whole personality this year. That movie, like I'm obsessed with it.
I was like,
so whenever you walk into a bar, you ask for permission now. That's all.
I was
No.
be outing myself as a
no, it's the
vampire.
other way around. Whenever somebody asks you permission to enter, you're like, no.
No, please don't enter.
Don't know.
So in that same idea that when certain people reach certain positions, they monopolize that position, and they also provide opportunities to very similar people that they are in their circles of.
That is true.
And then that kind of gets gate locked or like gate kept.
True. Like,
And then after that, when people are growing, like she said, there are people in the Native American communities, the black communities, the brown communities that are trying to grow. But they obviously don't get the same kind of opportunities. For example, if you want a PhD grant, it's limited to the people who are obviously, say, I am applying for a PhD grant to the UK. A lot of the big opportunities with the really large grant money is offered to very specific UK nationals.
so the distribution of exposure and power
Opportunity. It's a
the distribution of opportunity
opportunity.
is controlled by a group of people who themselves have their own biases about
Yes.
who they
Which
should grant it
happens
to.
in every industry.
Yeah.
So if you think of psychology as not, it is a very rewarding practice. It is a very enriching, helping kind of area space. But at the end of the day, it is also a part of making money and a business.
Yeah.
So people forget that part. Just like in the medical world, how everything is a business, in the MBBS world or
Yeah.
the MD world, same thing goes into psychology as well.
Yeah.
So then, Sharani, I would like to ask you a question on this front. If given the opportunity to hold a space like what is the name you mentioned? Beck. Sorry, I went to Beckham. My bad. Given the opportunity to hold a space like Beck's, and this question goes to both of you, what do you think you both need to do at this point in life, at this point of time in your life, with your experience, with your knowledge, to maybe not go as far as having an institute named after you, but at least be a prominent figure who other Indian subcontinent therapists can look up to, or other Asian therapists can look up to?
Well, Aaron Beck is popular because he came up with cognitive behavior therapy, which is like literally like
Okay, he invented something.
He's
an inventor.
I mean, like credit where it's due. He did
He invented something that we all use
that we
every
all
day.
Okay, so I'm aiming too high.
It's a very popular, probably the most popular kind of treatment modality there is. I don't do a lot of CBT, but
My
like,
God.
yeah.
So for those of you who want to know in footballing terms, I just asked them, if you are an amateur footballer, what do you need to do to be Messi?
Kinda, yeah. But I mean, that brings the question of, like the opportunity to do this kind of research. How does it go to people of color, right? And go to people from underrepresented groups. I mean, where does most research happen? Which country, which part of the world?
I don't know, but I will wager a guess. Okay? Why are you laughing?
Go ahead, wager the guess.
If it's supposed to be educational and academic, it has to be UK.
UK or the US? US.
The US also?
Yeah.
US big time.
I see some videos on
Biggest
TikTok.
researchers in the
Most-
world are funded from the US.
Yeah.
Oh, wow.
So the most
I'm
amount
very
of
surprised.
mental health research, or just like in most areas and specializations, comes out of the US,
Yeah.
Oh, wow.
right? So now for an Indian researcher, to do research, because so much of the funding is over there, right? To do research, they need to be able to afford to go to the US and study over there at a
So
university.
already a big chunk of people who might be good enough are off.
Yeah. And even there, now, if all the research is coming out of the US, you're again studying the weird demographic, right? White, educated, industrialized, rich and part of a democratically elected government.
Of course, yeah.
Yeah. Quote unquote. Don't forget the quote unquote.
But
Subtle jab there.
so yeah, like from the get-go itself, there's like 1,000 barriers, and
Yeah.
then when you get there, another barrier is how do you kind of work with the populations that you need to work with. And that brings also the question of how do we do research in a way that actually like works and is designed for the populations we're working with, right?
For me, honestly, the question that I'm getting right now is why is so much money being pumped in by just the US and UK? Why can't our countries pump in that much money? Because India does have money to pump in. So why aren't we pumping in money? It's not
These are
like
very good questions, but the answers to that are very limited. Because in a lot of these cases, the countries have other objectives that they need to fulfill first. India is not behind. They're right now, for example, currently, I see a lot of this on LinkedIn because I didn't study in any Indian university or any Indian capacity, so I'm not very aware. But I see that they're working on the regulations of psychology at this point.
Yeah, and
Regulations,
they kind of on the struggle bus a little bit, like the Rehab Council of India. Like we can't get licensed in India because our
Why
degrees
not?
are not from India.
wait.
Yeah.
So you guys have you've studied in
King's College, yeah.
You studied in which university?
Like at Durham University in
there you
UK,
go.
and then like Xavier in the
So
US.
you
There you
both
go.
have studied in one of the top universities in the world.
Yes.
But you cannot get a license in India.
No.
Why?
Well, like my degree is only accredited by the American Psychological Association. Like,
They have interesting policies. I'm
Yeah.
sure you can equalize it and stuff. It's just a longer process. And currently they have something called an MPhil
Yeah.
that they're trying to work
But the
through.
MPhil was abolished.
Yeah, they got rid of it, and I don't know what's happening.
yeah,
now.
they
Which makes
got rid
me
of
feel
it.
terrible for everyone who has actually invested in
and a lot of
MPhils.
people are still
Yeah.
in the MPhil process. So they're really so what I look at it as is at least it's a sign that they're looking into the regulations and the policies.
Yeah.
And again, we are not very clear on the policies, but what I do understand is they want to make it a little stricter to run these practices, because a lot of places I know, a lot of people I know who are practitioners in India, I keep noticing that they keep posting these things. This person says that they're a therapist. They are not. They are not licensed. They don't know what they're talking about. They did mass communications in bachelor's.
Okay.
And they did mass communications at university. But they're just pretending to be because they want to run a business.
Okay. But
That's why they're working towards the regulations to make it
But
better.
honestly, personally for me, like logically speaking, the regulations are very important. I 100% agree. I'm not going against the fact that regulations are necessary, but regulations should be there on who practices once they start the practice.
Yeah.
So there shouldn't be barriers in getting into psychology.
Yeah.
Barriers to
Yeah.
entry.
Yes.
Yeah.
Once you start your practice, then there should be a regulation on how you are implementing
Absolutely.
your knowledge.
Absolutely.
That I can understand. Maybe send mystery shoppers, not
Mystery shoppers.
patients.
Mystery patients.
Mystery
Oh my
patients.
God.
Like figure it
I
out.
volunteer to be mystery
Yes, I
patient.
would love to be a mystery patient.
I see dead people. But no, find creative ways of implementing regulation rather than hindering people. Like, for example, if you guys have invested so much in your education and you are so qualified, then the country is losing out on somebody who would love to go back to the country and work over there, but they can't because it's...
Yeah, because I wanted to work like with clients in India, if virtually that's allowed. And obviously I would have worked with like the lower risk and not the high risk, because like online and I'm here and they're there, like I wouldn't want to, mess with high risk it would be too risky. But I wanted to do that. But ethically, I cannot do that because I cannot get licensed in India.
So you're telling me it is easier for a businessman to invest money in the country, but it's not, it's infinitely harder for a therapist to go to the country and give psychological help to people who need it in the country.
Pretty much.
Pretty much outsiders, pretty much.
Yeah.
But I'm sure within the country they're trying to make it easier.
Yeah.
So they're trying to weed out the fake ones. So I think they're starting there, and then they were like,
Those are entirely separate issues.
I understand, but then we as culture are not very good in isolating our problems. We deal with it altogether.
I mean, me having issues with multitasking, I can understand. I'm one person. A government entity can have different departments.
Yeah, different departments. One weeds out all the quacks.
Yes.
Right? One kind of works on helping people with foreign degrees get
Yes.
licensed. Yeah, yeah.
Who hires all these people?
And the fun
That's
part
the
is
problem.
the fun part is this also takes care of a massive unemployment issue that we have in the country right now. So it generates employment.
There
Yay!
you go. Did you solve unemployment? Wow, I like that.
I would like to run for elections.
I like that you're speaking about barriers, because I think moving away from research, and we understand the complications with research, and we understand the complications at the student level, whether it is equalization of our certificates in India, or whether it is introducing the idea of a diverse multicultural concept in the education part. Once that's all done, to a layman, to a
Yeah.
regular civilian, a general population person, they don't know any of this. What stops them from getting into therapy, especially in a South Asian community? What do you think?
Oh,
Treasure trove.
oh my gosh! Like that one is it's such a big question. Literally, it's everyone kind of throws the word stigma out there, right? Like it is that stigma for sure of the understanding of mental health challenges, and we look at kind of the history of our countries. Like our grandparents grew up in a colonized India, like mental health issues, and unless they got so severe that it was a risk to your life and of others, it was a privilege to feel depressed.
Correct, yeah.
Like you like honestly, like
Yeah.
you had to feed your 12 children, and
You don't have time in a day to feel depressed.
Yeah.
like literally it's a privilege to feel
That is true.
depressed on like a kind of low to
Verbalization
moderate
level.
level.
Yeah,
Yeah,
yeah.
But another big factor is that South Asians, and now this could be because of our culture where we don't talk about these things as much. It could be just how it's expressed like in our bodies, but mental health issues pretty much always show up as physical health issues in South Asians. So they're going to the doctor to figure out, why is my stomach so goofy?
Yeah.
Why am I having heart palpitations all the time? Why does my head hurt all the time? Chronic migraines, digestive issues, all of this. That's how it shows up. Backache, shoulder pains. And it doesn't get recognized as, there is something here that's not kind of just organic. There is more to it. Like the mind is at work over here, right? So that's a big factor, that people just aren't even aware that they're struggling with their mental health.
And that's also because historically, I mean, South Asians don't know their own history. Because historically, we have been very prone to famine.
Yeah, exactly.
Because we were so prone to famine, our bodies had to readjust a lot.
Exactly.
Since that time, generationally now, we are not very tall, and we store a lot of fat, and all of our problems are stored as physical manifestations.
Yeah.
Exactly.
That is where all of our problems stem from. So because of those reasons, we do not understand that. Like I have a friend, every other week she has a new different, either her back gets thrown out or she needs to get an x-ray done, and I'm just like, maybe. And she's gone through a lot in her life, and she was like, you know what, I think I need to start therapy. I'm like, yeah. I think you should. She's like, maybe this is psychosomatic. I'm like, wow, look good for you.
Wow.
She came up with the word all by herself. She was just like, the vagus nerve? I'm like, yeah, I do.
Oh
Go on.
my gosh.
Go on. I like this. Keep talking. And then she's just like, you know what, now I think we just need to get into therapy, and that's the only avenue that's left.
Yeah.
So she's come to a conclusion that now that I've eliminated every single doctor possible, the only avenue that is left is a psychologist.
It's the final.
So I think in the South Asian culture, like you said, there's so many barriers. One of them is our priorities
Yeah.
are not this. It is just not this. Like we have.
And it's also like, now I'll give you my example. I keep coming back to this example. When I was in 5th grade, now they didn't have a word for ADHD in school, but my teacher started noticing that there might be something wrong with this kid. And she just mentioned it to my dad, that maybe get him checked. My dad got very offended.
Yeah.
And this is it. And it's just like, it's a huge thing. Like an aunt of mine had to go to therapy. So the fact that she had to visit a psychiatrist was like discussed in the entire family. Like, oh my God, she has to go to a psychiatrist. What is wrong? There's nothing wrong. She had anxiety.
Yeah.
So she was recommended by her physician to go to a psychiatrist. And it was only when that anxiety had manifested itself as high blood pressure, it manifested itself with sleep deprivation and a lot of things, and that it's not like step one, you go to a psychiatrist. No, it has to reach a point where it's like cross the threshold.
Yeah. Like it has to get almost as bad as it can possibly get before someone actually gets help, which is why, like, remember I talked about how, like, in India, they did this research with medical facilities of getting people like mental health support in kind of medical facilities, right? So this is a whole branch of psychology that's kind of developing and has been over the past few years of behavioral health. Right? Behavioral health consultants are people who work in kind of primary care setups. Like if you go to your Aster or your Novomed, behavioral health consultants would be employed at places like that, where people show up with kind of, physical ailment, whatever, they go to meet their general physician. And now another layer here is that, like, medical professionals and medical doctors, general practitioners also need to have that kind of awareness of when things are showing up, like mental health issues are present along with physical health issues, or is this a mental health issue manifesting as a physical problem, right? That is a separate, whole other topic. But when someone goes to a doctor, that's obviously much more socially acceptable, right? Within every community, not just...
Because the ailments are visible. You're coughing.
Exactly.
You have a fever. The temperature is high.
Exactly.
You have a wound on your face.
But it's also not considered a moral failure to be sick physically.
Yeah.
But to be mentally ill is considered a moral failure.
No, like the example I gave you.
Yeah.
So her husband must be doing something.
Yeah.
Or her parents did something that she didn't raise her well. She's not praying enough. So that became, which brings, that's a fun question I have. So the way we have, there are religious barriers to in every religion to therapy. So the way we have something like Islamic banking, right? There's a version of banking that is adjacent
Without the
to
interest,
adjacent to Islamic practices. Do you think it is possible to have therapeutic practices, psychology practices, which are in line with different religions, like Islamic therapy or Christian therapy or Hindu therapy?
100%.
And they do exist.
They do exist as
really?
well.
And they do exist.
Like Quranic recitation is like a part of like a form of CBT that is done like with Muslim populations.
I did not know this.
Yeah. And it like has better outcomes than if you just have someone do like regular CBT without incorporating faith into it.
And a lot of Catholics, for example, would prefer going to the priest or the counselor at the church for their marital problems than a marriage counselor. And they find that they also respond better and get better results for their marriage if they go to someone, especially if they're of the religious kind.
Yeah.
If they go to someone religiously aligned.
So you're saying that if there is an actual priest psychologist or more
they're trained. So all clergy are also trained. So people who run parishes have to be trained to...
Oh, that's
I don't think it's
amazing.
called a parish in Catholicism. My bad.
Churches?
My apologies. I don't know what that is... that particular community. I do not know the name. But
That's very interesting. I did not know this. That's amazing.
You also have pre-counseling before marriage.
So that is
That's
literally
mandatory.
decolonization.
Well, see, again, like when it is with like, it's specific to this faith, right? Like the Christian faith, right? And so it's starting off within a subgroup of the white population, typically mostly white population, right? Like Christian faith. So it's starting within that population, but it is starting to show up with other populations of religious populations that have more kind of like black, brown folks.
Yeah.
Fair enough.
So it's like, it is a concept of, because religion itself or religious practices does not completely define a culture or a community.
Correct.
It is just a part of it. When we talk about
When we
decolonization,
are talking about South Asian communities, it's a massive part of it.
it is a massive part of it. So the Quranic verses part in CBT is a big win.
Yeah.
Especially if that works is
Yeah.
a big win,
course.
because a lot of people have tried, a lot of people are working towards, I don't know, I used to know a psychologist in 2015, 2016. She was working towards becoming a counselor in her mosque.
Oh, wow.
Like that's where she wanted to be placed to work with her particular community
huge.
for domestic abuse victims.
It's amazing. I
Yeah.
genuinely did not know this. So, like, when I asked this question, I thought the answer was going to be, yeah, we don't have it, we're working towards it, or something like that. I didn't know there were
Well,
actually
no.
things like that present.
So there's my aunt recently like visited this temple in I think it's in Kerala. It's called Chota Nikare, okay?
Okay.
And now I don't know how, like she said she saw this. All right, I tried to find it on the internet, I couldn't. Okay, but she saw it and she said, like, so this is a temple where typically they take people who are possessed or supposedly possessed.
Okay.
Right, and then there's like exorcism and whatever and prayers and all of that is done to get this, whatever entity is possessing them, exorcise them. She said when she went there, right there on the compound of the temple, there was a mental health clinic. I tried to look it up on their website. I couldn't find it. Okay. But she said there was literally a mental health clinic in the compound of the temple, right? So a lot of times, right, like this, what could seem like, someone is possessed by a demon or something could be like like psychosis, like, like schizophrenia like symptoms kind of that have set in, like someone seeing things, hearing things, behaving unusually, right? It could be that. It could be like a very adverse reaction to a very traumatic event, right?
So the temple you're speaking about is the Chotanikara Amman
Yeah.
temple
Yeah.
in Ernakulam, Kerala, India. Yeah, so there it is written. The priests, they do practice their healing, their pujas and their bhajan, all of that, all of their steps they do complete, but they also encourage medical advice.
Beautiful.
They encourage medical advice and they ask the patients to seek and continue medical and psychiatric advice for better sleep and adherence to prescribed medications.
See,
And that is a
nice.
phenomenal way of making, of destigmatizing therapy within the South Asian community, right? A priest is considered a person of respect, of high esteem.
Yeah.
A doctor is considered a person of high esteem and respect in the country.
Yeah.
That is how you kind of get people to open up to the idea of it.
Yeah, we like going back to the original point you guys made about leaders
Yeah.
Yeah.
in the community. Yeah.
So this really supports it, because a lot of one of the major barriers is your family going, like you said, the image of the family, the reputation of the family. If someone that they value with such a high regard, that person is telling you, please take the medication, please seek advice. It's not only like, it's good, I should do it. It's more like it's a respectable practice.
Yeah.
They associate it with the word respect quite easily.
Yeah.
Because a lot of us, a lot of South Asians are indoctrinated with the idea all of this is wrong or quote unquote white.
Yeah.
Or this is not a part of our culture. So all of this takes a back seat and the values that that person presents takes a front seat. So it's a great position to be in. So more of that is what I think all of, even individual practitioners, as like Sharanya, myself, and a lot of us, this is what we try to work towards. Yeah, and I think even within the white communities, there is a need. For example, a lot of Italian speakers would prefer speaking to an Italian person.
Yeah.
A lot of Spanish speakers would prefer to speaking to a Spanish person. A lot of Arabs would love to have a therapeutic session or a therapeutic discourse with an Arab person. So the more we work towards building these leaders, that is one of the things. You know how we said, how do we get to an Aaron Beck position? This is it.
That's how you
where
do.
we
Then
start.
You get to an Aaron Beck position within your community.
Yes, from that point on. So one of the other things that I wanted to ask was, so we've now covered research, we've covered student relationships and student ideologies, how the culture and community play a huge role. The Gen Zs and the millennials, or the late millennials and the Gen Zs, or whichever, they know mostly that it's not as stigmatized as it is. But yet their reach, yet them going and accessing therapy is low. like a lot of my friends who probably are very well versed, who have these conversations with me all the time. I'll be like, why don't you go for therapy? Like, nah.
Yeah.
It's not because they don't know. They know it all. They know
Yeah.
people are working towards it. They know there are people who are making it more culturally relevant. What is the barrier now?
Yeah. And I think, one, like, the person doesn't think it's serious enough.
Yeah.
Right? Because again, let's remember, for South Asians, it shows up more as physical manifestations. I'm
That's
feeling
right.
tired. It's probably I just need to get more vitamin D. I probably need to get like iron injections. I probably, just need to work out more, improve my diet.
Yeah,
right?
off your phone, sleep early.
But we also don't like kind of recognize, like, it's okay. So there are a big part of it is also people's lack of understanding of what can actually trigger mental health issues as well.
Yeah.
Right? Nothing major happened to me in my life. Like, I went to school. I don't have to worry about money. I have a good job. Why would I have a mental health problem? Right? It's our understanding of what constitutes a traumatic event itself is like, no one beat me when I was growing up. No
I
one
wasn't bullied. I
assaulted
wasn't
me.
abused.
Yeah. So why would I have a mental health issue, right? So we need to kind of first off deconstruct what trauma looks like itself and reframe our understanding of it. It could be, like your parents got divorced and you had to fend for yourself.
Could be as simple as your best friend moved away.
Your best friend
Yeah.
moved away.
Your whole identity was attached to that
Exactly.
person.
Or you got lost in a mall for 30 minutes.
Yeah, your
As a
parents,
child.
you couldn't find them.
Yeah.
Or you moved, like, when you were like 10, 12 years old, you moved to a different country and like you couldn't like adjust as easily.
Yeah.
You probably grew up not like neurodivergent and not being diagnosed with it, so school was really hard for you. At so many levels, like, your identity is being questioned, your sense of community is being taken away from you. It's not just those extreme examples of where your very sense of safety is under question, right? We also we also kind of look at our experiences from the lens of an adult, right? We don't understand that sometimes, if you grew up as a child and your parents couldn't understand you, couldn't hear you when you needed them, they weren't able to be there for you the way they needed to be there for you. As an adult, you're just kind of like, it's okay, like, I got by, it's fine, I made friends, it's okay. But for a child, think of that experience from the perspective of a 4-year-old. Okay, like, your parents are not understanding that you need something right now. You're crying, and they're yelling at you, all right? Or they're just ignoring you. How would that register in a 4-year-old's mind? How would that register in a 4-year-old's body? For a 4-year-old, not having their needs met by their parents is literally life or death.
Yeah.
Right? And that's what kind of stays in the body. That's what we mean when we say that trauma is held in the body.
Yeah, and then that kind of results in the brain makeup, the brain map that then leads you to be an adult who's ambivalent, avoidant,
Exactly.
who has attachment
Anxious,
issues,
yeah.
anxious, gets immense rage when they drive.
Yeah.
All of this comes from that particular moment,
Yeah.
but you don't recognize it.
Exactly.
A lot of us late millennials, Gen Zs, early millennials, we don't recognize it. And Gen Zs are going through something else. They're also going through the fact that this world was not made for us. Just to deal with that itself is quite traumatic. You're just like, wait, none of these structures work for the mindset we are in.
Yeah.
Because the evolution of the world, like Gen Alphas are so different from Gen Zs.
Yeah.
But Gen Zs are going to create a world for them, so it'll be easier for the Gen Alphas.
Yeah.
But generations and Gen Zs tend to then suffer the consequences because they don't understand the work policies. They don't understand why we have to slog this way. They don't understand why everything's expensive.
And there's also-
they don't understand any of it.
There's
And that
also-
creates a scar in your brain.
And there's also a massive disconnect in the policymakers, the ones who are in power, who are the pre-millennial generation. Which one knows that? Gen X?
Yes, Gen X.
Yeah.
Gen X,
So
yeah.
Gen X are the one in a position of power to make all the policies and everything.
And they are following what the boomers
What the boomers told them, and then when Gen Z go like, no, this is not making sense. You're all lazy. Your entire generation is lazy, and that's like, how do we break out from that? How do we separate from that? And the millennials in the middle are just like, we don't even know what's going on.
We don't know what's going on. We had CDs 2 minutes ago. Now we have iPhones, iPods. Wait, no, they're gone too. Like,
Yeah.
I don't know where they are.
I started school with floppy disks. I went to CDs. I went to USBs, and I'm like, okay, fine, like, whatever.
I don't know what they use in schools anymore for data transfer.
We
Cloud.
transfer.
Oh, just
Cloud.
WeTransfer.
Yeah.
WeTransfer is problematic. Besides the point. But besides the point. But
We are now segueing into another discussion. Please.
I take it back. I take it back.
We're not.
I retract that statement. One of the things, like I said, is also expensive.
Yes, big factor. Yeah.
But the mental health services that we offer are also expensive.
Yes.
It's a huge factor when it comes to.
But it has to be expensive because just looking at how you had to go through your process to get CDA license,
Oh my God.
I was like,
Oh my God.
if you're spending this much money to be able to apply the education that you have received, first you have to spend money to get the education.
That's right.
Okay. Then you have
And because we wanted credible educations, we went to expensive
Yeah.
universities.
yeah, expensive universities. Otherwise, it won't be recognized anywhere. Anyway,
Yeah.
I mean, your credible universities are not recognized in India. So, like, imagine if you didn't go to credible ones, and then you have to come back to your wherever you are. You have to work towards getting accredited or not accredited, recognized
Yes.
to practice in that region. And when you're able to do that, you realize no, that's not enough. We have to continuously renew.
Yeah, you
that
renew it
license.
every
You have to
year.
renew it. So you have to have like, well, for the CDA, it's like what
40 points.
40 CPD points. So getting kind of continuing education, like getting trained in modalities and whatever. Like I recently did my EMDR training.
Yeah.
It was $1,700.
Wow.
Hive movement desensitization
And reprocessing.
and reprocessing. Thank you.
Yeah.
I was going to say resonance, but yes.
So
and
fun.
reprocessing.
What was it? I lost the
Eye
abbreviation.
movement desensitization and reprocessing. So it's
It
a
is
trauma
EDRT.
treatment.
It's a trauma treatment.
EMDR.
EMDR.
Yeah.
Where is the T?
There wasn't one.
Oh, okay.
There wasn't one. That was the ADHD brain. Welcome. It was missing for a bit. Now it's back.
Hello.
But yeah, I mean, and then like in Dubai also, like building your caseload is like tremendously difficult. Like if you're an early career professional in Dubai, an early career psychologist, so here the way you don't work on a salaried model, right? You get paid, you get a commission,
Revenue commission.
Revenue commission.
it's revenue share. Yeah, so every client who comes to see you, you get a cut off that session's cost, right? Now, to get recognized as a reputable clinician in Dubai is a whole task, right? That's one whole thing. And people like Aditi and I who like, you know, are very confident speakers and we put ourselves out there and stuff, it's easier for people to know who we are,
Yeah.
right? But for a lot of people, and also for me, thankfully, like, you know, I did not have to survive on my own with no income, you know. I have very supportive parents. I could stay with them. They were like looking out for me and continue to,
Not
you know.
everyone has the support.
Not
system.
everyone has that, right? So, and a lot of people have reached out to me about, hey, I want to move, like, you know, I'm doing my CDA process, but, you know, financially I'm kind of struggling. How do you suggest I go about it? They've reached out to me on LinkedIn and I've been like, hey, I would, if you cannot financially support yourself for at least 1 to 1.5 years, I would not come to Dubai to practice as a psychologist,
Yeah.
right? You cannot survive,
Yeah.
right? And this brings to the cost of therapy, right? It's not just like, you know, you, first off, a bigger issue is insurance coverage is not good for mental health stuff over here,
Yes.
right? That is at like that systemic structural policy level that needs to be changed.
Yeah.
So you see a lot of white folks or folks in, you know, like Western countries going to therapy because insurances have kind of caught up
Yeah.
to covering the cost of therapy or reimbursing people for what they've paid for therapy, which is not the case over here. So if you have a severe mental illness, all right, someone who needs, like you have complex PTSD, which is a whole other topic, but insanely difficult to treat, can present with a lot of high risk behaviors, needs constant support. Like 1 hour a week is not enough. They probably need 2, 3, 4, 5, 6 hours a week of therapy, depending on how severe it is, what services your clinic offers, that kind of stuff. Psychiatric support. For a case like this, someone will need years and years of therapy. All right. I had a client who was with me for 6 months. All right. And then finally, like, they had to terminate, and it was a teenage girl, you know. They had to terminate because in 6 months they had spent like 23,000 dirhams.
That's a big amount that makes me want to take a walk.
You're taking a walk, you really are. Okay. I think the problem with not just the 23,000 dirhams is he actually did take a walk, guys. I think he needed to just decompress for a bit. I think the problem with the 23,000 dirhams is that even if you put that kind of money in,
Yeah.
it's not enough.
Yeah, it's not.
It's not enough. You're back. Do you feel okay?
Yeah, that was a big amount.
Yeah. Did you feel okay?
Yeah.
Like I was just telling her, even when you put that kind of money in, it's not enough. You need more for such cases. And you were saying, right, it's a systemic issue where in the medical insurance packages and everything, they do get a certain level. So
Yeah. It's
the
like
premium ones, 10 sessions.
Yeah, or it's like six to 10,000 dirhams.
Yes, whichever comes first.
I'm not
Yeah,
going to walk
Correct. Yeah.
And like 6 to 10,000 dirhams, that's including your psychiatric appointments. You know, so that's like what, 5 to 6 sessions of therapy?
Yeah, that's after that, then maybe the cost cannot be brought down, because then you have to first break even on the investment you have made in yourself.
Yeah.
To reach this point, then you have to make the money that you need to invest to keep that license active. And then on top of that, you need to make money to survive.
Yeah.
Yeah. So even in a lot of cases, like, so I work for a clinic part-time it's a clinic that deals with a lot of lower income families.
Yeah.
They try to promote it amongst them and stuff like that. But because it does that, we run out of resources quite quickly.
Yeah.
Because obviously the income that comes in, because they've hired really good professionals. Okay, they don't want to hamper the quality
Yeah.
that they offer, and they have hired them, so they obviously have to give them something.
Yeah,
Right?
obviously,
Because they have hired them for their expertise. Like an artist who's worked for 30, 40 years gets that amount.
Yeah.
So a person who studied and is a proper professional should also be appreciated, which I
100%.
completely understand. I completely appreciate. But we run out of resources quite quickly. We run out of we don't have this kind of assessment because it's an expensive assessment.
Yeah.
So we can't have it in this. Yeah, it's an
So that is also a thing. So, like, for example, if you're doing CBT.
CBT is not
No,
an
no,
assessment
CBT
base.
No, just like a separate question.
Yeah.
So, like, for each student, if you make an account, you're paying somebody for it.
So different things. So what you're talking about is something related to cognitive training. So CBT is cognitive behavioral therapy. So that's
Yeah.
a therapist who would run that session.
Yeah.
That's a talk therapy format. But
Okay.
what we do is in psychoeducational assessments, we use a lot of assessment tools to
Okay.
assess and see if a person has any markers of neurodivergence, any autism, ADHD, all of that.
Correct.
For that, we need tools.
You have to pay.
And those tools are expensive.
Yeah.
Okay.
Yeah, so not every clinic can be equipped, and some of the tools cost over $5,000.
So
Not per
even
tool.
if you want it to be affordable for
The systemically,
marginal communities, you cannot be.
yeah, systemically it's tough.
Yeah.
So think of a clinic in India who has
Yeah.
to. We all have access to the same website to buy those resources. The
Yeah.
resources, like we have said, is westernized.
Yeah.
So it also has a westernized cost. So think of a small clinic in India; they cannot afford
They
it.
can,
Think of a small clinic in Pakistan, Bangladesh,
even if
any
the
of those
clinic can
countries.
afford it, they cannot charge that to the people who come to
it
them.
cannot. Obviously, the 5,000 model is for one assessment is there with you for a long time.
Okay.
But if you take a digitalized version, there's a different cost. If you take a hard copy, there are lots of things attached.
And every time you administer that assessment, there might be like
A
an
royalty.
additional
Yeah.
cost that you have to pay.
And
for.
none of these have a like a
Lifetime.
No, not lifetime. Sorry, there's a word I'm looking for. For subsidized version. There's no subsidized
For
version.
research, I think they sometimes do subsidize and give, but I
As a
haven't come
practice, they don't.
across.
So the
Yeah.
best kind of subsidized version we do is alternatives. So instead of, like a very good example would be, instead of running an ADOS, which is the autism standard test, you do indirect tests like CARS and GARS. CARS 2 and GARS 3 are also, these are names for
Oh,
the
okay, okay,
assessments.
okay.
Yeah.
These are also very well recognized, but those can only be used if you're a multidisciplinary team.
Okay.
So then comes the other limitations. You need to have a speech therapist, a special educator, and a psychologist.
All
Then
of which
only-
requires
Yes.
investment, further investment.
Correct. So for every path you take, there is a small obstacle that presents itself.
So essentially what you're saying is, while yes, we should decolonize therapy and everything, at the end of the day, even then, therapy will not reach a lot of people, because a
It's-
lot of people, about like, is it safe to say that about 80% or 70% or 60% of the people cannot afford it?
Yeah.
It depends on the population, but a 60% of middle class people will not be able to afford it.
Because it's a weekly expenditure, right? You're paying what, 700 to 1,000 dirhams. It's not like I go see this person once every 6 months. It's every week. So it's only accessible to the wealthy. Right.
Which then
Or the
bring-
comfortable.
which in then the South Asian communities brings us back to the point where they only go for it when it reaches a point of
Correct.
no avoidance.
Yes, correct.
Non-avoidance, not
Even wealthy and comfortable and extremely rich South Asians, which there are many, especially in the country we are in,
Yeah.
there are many,
Yeah.
Are very resistant to
to spending
spending
that.
that much.
So even the wealthy ones don't want to spend.
So they would rather see a therapist online from India. So they'll pay like a fraction of the cost to see a therapist. Like what they would, they'd pay maybe like 200 to 300 dirhams to see a therapist in Bombay, okay, versus 700 to 1,000 to see a therapist in Dubai. So they would much rather do it online.
Well, even when you put it that way, then kind of makes sense.
Yeah.
Yeah,
Kind
it
of makes
does, and
sense.
we
Like,
don't
if I
deny
was in
it.
that position,
Yeah.
I would do the same
We
thing.
don't
Exactly.
deny it, but we always talk about the accessibility feature, which is in an emergency situation.
Yeah, you
we are
can't have
here.
online. Yeah. And there's a time difference and everything. And
Yeah.
So that kind of insurance thing, I'll just like, because there's these barriers to insurance, right? And being able to cover the cost of therapy, there is a lot of limitation with offering what we call higher levels of care as well. All right. So we've got like the regular outpatient where someone comes, sees you once a week, and that's it, right? Then we've got like intensive outpatient, which is where the person, it's for more kind of severe manifestations of mental health issues. They need more support during the week. It's like 6 to 9 hours of therapy. So it'll be like individual and group therapy, right? Then you've got residential care, then you've got inpatient care, okay? None of those things are like intensive outpatient, residential, inpatient even. Those things are not possible if there's no insurance coverage. Because imagine if it's like 700 to 1,000 dirhams to see a therapist once a week, how expensive would it be for 6 to 9 hours a week? How can they even possibly cover the cost of that?
Not possible.
That's the same thing. It's the same idea that when you get really sick, you have pneumonia, you know how you're just at a doctor, you're just at the
Yeah.
hospital for a long period of time.
And then whatever cost comes up, you pay.
You pay, or you have thankfully a good insurance that covers
yeah.
it. Systemically, if the insurance barriers kind of expand towards mental health,
A lot of people will be able to go for it.
that's when the accessibility will increase.
And clinics would also be able to put into place programs like intensive outpatient to support like the higher needs
Yeah.
of the
which
population.
is a good point, because I've been working since 2006. The only time I had an insurance which supported therapy
Sigma.
was between 2020 and 2024.
There you go.
Cigna?
I don't know the name. The company gave me insurance.
Yeah, it was probably Cigna. Cigna does like...
I think it was no. I do remember Medcare,
Okay.
MetLife.
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 Okay.
Medcare is a
Yeah, sorry, MetLife.
hospital.
MetLife. Yeah.
MetLife. MetLife also has really good, and which is the other one? Axis. There are AXA insurance. So AXA insurance, MetLife. These are the ones that offer, but again at a premium rate.
So could you guys say that again? Just so you mentioned one name as well at the start.
Cigna.
Cigna, and what were the other names?
AXA
AXA,
And then you said MetLife.
MetLife.
These
But-
are the ones that, again,
But then the companies who can afford these
Oh yeah.
insurances are like for the higher level kind of executive employees and like
No,
for
but, for me, my company gave it. I was a very entry level employee.
Okay.
Little more than entry level, but that's it. Not even middle management. So I had access to it. But the thing is, these companies, they demand so much work that you don't have time to go for that. You're working till 2 a.m. It's like, no, I just want to sleep.
so guys, thank you very much. How was that? That was very lovely, actually. I actually really enjoyed
I really
this
enjoyed
conversation.
that.
This was fun.
Yeah,
This was
yeah.
really
We
fun.
learned a lot about the barriers and how South Asian communities and other communities view.
Yeah, my biggest takeaway was the fact that they are religion-centric therapies.
Yes.
I didn't know that. I didn't
There
know
you
that.
go, a big win. You've learned something new, Al.
I've learned something new. I'll forget it in 10 minutes.
Thank you very much for joining us,
Thanks
Sharanya.
for
It was
having
really
Thank you so
lovely
much.
having
Thank you.
We will call you again because this was fun.
Yeah, I'd
Yes,
love
let's
to be
do
here
more of
again.
this.
For sure. For sure.
Next time we should have a gaming session.
Yes.
And we talk while playing game. That should be a thing.
We should do it. Yes, we just ask Tayyab to set it up
Yeah.
and he will not run.
And we
And
can
he also
talk,
play
like
with
it can
us.
be like a Twitch stream kind of thing. You know?
Awesome.
We're
We'll
like
just have it.
playing and we're talking about like therapy stuff.
So, yeah, do you have a PlayStation?
He's
No.
No? We'll buy you one.
no.
I have a PS4.
Done.
We can collectively bring all the PSs we have and see what happens.
Yes.
Okay. Thank you very much. Thank you very much. Thank you, Tayyab, as always. And see you guys later. Take care, everyone. Say bye.
Bye. Thanks for listening to Best Part Is with Sid and Adi. We hope you enjoyed this episode as much as we did. If you loved what you heard, make sure to subscribe, rate, and leave a review on your favorite podcast platform. Stay curious, stay inspired, and keep looking for the best part in everything. This is Sid and Adi signing off. See you in the next episode of Best Part Is.